getting started. So welcome everyone to our UCSF Orthopedic Surgery weekly grand rounds. Today we have Dr. Santiesteban, one of our faculty members and hand surgeons. And for an introduction, I will turn it over to Dr. Schroeder.
Thanks, Drew. It looked like you were eating pizza. Good morning, everybody. I'm very excited to announce the second of our new faculty members who will be giving grand rounds. And this is, we like to call her the OGLS. So Lauren Santiesteban, who is the second because the first being Lauren Shapiro. But she is the OGLS, meaning that she was our fellow last year, and we were lucky enough to have her stay on. So Lauren hails from Indiana and is a true Hoosier at heart. If you've ever listened to her talk or see the podcast, everything, she's a little bit Midwest. And I say that in the nicest way because I also am Midwest. But she has, went from Indiana to NYU and is now here with us today after having finished her hand fellowship. And she's primarily based out of San Francisco General, but also sees patients in Marin, where I will be joining her hopefully when we get some space for me over there. But she is a outstanding addition to our service. She is probably the kindest, hardest working person I've met and fellow that we've ever had. If anyone has ever interacted with her, she just brings a smile to your face, and she's a wonderful addition to our service. And so without further ado, she's going to be talking to us today about healthcare disparities in hand surgery, which is a growing interest in our group. And I think she has excellent firsthand knowledge of this. So I will turn it over to Dr. Santiesteban.
Well, thank you, Dr. Schroeder. That was such a wonderful introduction. I appreciate it. And good morning, everybody. Can everyone hear me okay? I just want to make sure before I start rambling.
Yes, sounds great.
Okay, good. And you can see my screen okay as well, correct? Yes. Okay, good. So thank you so much for having me. I really appreciate the opportunity to discuss this topic, which has not only been an interest of mine for a long time, but I was also inspired to learn more about this after starting as a new attending here in my first few months of practice. I noted that during this time, I had multiple recurrent patients that were coming in to see me who had difficulty accessing a hand surgeon, seeking care because of their insurance, because of language barriers, culture barriers, whatever it may be. And so in particular, I want to focus on one of my patients in particular. This patient is a 41-year-old right hand dominant female who initially presented to one of the physician assistants in Marin in early December. And she sustained a sharp laceration to her thumb in the middle of October, so almost 7 weeks prior to presentation. She was noted to have inability to actively flex her thumb, and she had numbness as well in the radial aspect of her thumb. On exam, she was noted to have a zone 3 FPL laceration, and she had decreased 2-point discrimination in the radial digital nerve distribution. And so just to go through her timeline of her presentation, her injury, and her treatment as well. Her date of injury was the middle of October. She was seen at that point in Novato at an urgent care facility. They recommended that she seek hand surgery care right away. Due to many issues, she was unable to find anyone that accepted her insurance that could see her in a timely fashion until the early December. And she was then seen by one of our physician assistants. At that point, it was deemed that she had a subacute injury of her flexor tendon. And so an MRI was ordered in order to determine where her proximal and distal stumps were to plan for surgery. The MRI was ordered to be done in a quick manner within 72 hours. Unfortunately, because of her insurance, it was not done for over a month. And at that point, her MRI was completed. She saw the physician assistant again in Marin a couple of days later. I was contacted about her, and I spoke with her directly over the phone and said, we need to talk about surgery, blah, blah, blah. We need to get you in ASAP. And then also I need to get you started to get you in to see hand therapy as soon as possible. So we planned for all of those things. She came to see me for the first time in Marin, and then she had surgery in early February. And ultimately, because of insurance issues, yet again, there were more hurdles to battle, and that what led to her having a kind of not horribly delayed presentation to therapy, but the earliest we could get her in was a week after surgery, and that was in San Francisco, and she lives in Novato. And so you can see that from the time of her injury to the time that she actually had surgery, that was over 100 days difference between the two. And just to name a few of the barriers to care that she had, and I'm sure there were so many more that I don't even realize. For one, she was a Spanish-speaking patient, so she and I were able to communicate well, but she had difficulty communicating with other people with various offices in Marin, and also with my staff. She has partnership health plan, and as we all know, it's very difficult to access subspecialty care with this health plan. I actually looked at their website to see if I could find a hand surgeon in Marin, and oops, not able to find the results you are looking for. So that's unfortunate. Not only that, but when you Google health partnership and hand surgeons, this is where she lives. You can see here in the star in Novato, and you can see how far away all these hand surgeons are from her. If she didn't have access to a car or to transportation, it would be very difficult for her to seek care. In addition to that, by the time she presented to our team, she had a subacute injury that required further workup, which required more authorization. And even though the team was on it right away, it still took weeks and weeks to get that done. You also have to consider her therapy, what she's going to need after the surgery. And she really had difficulty accessing any occupational therapy. In fact, this is where she lives in Novato, and she has to drive all the way down to the city to get therapy twice a week. And that's a huge issue. That's 45 minutes. And then last but not least, all of the time away that she had to spend from work. So she is a house cleaner. She wasn't working from the time of her injury in middle of October. And now she unfortunately has to deal with the rehab and not able to use her hand to do her work that she needs to do to support her family. So this patient is just one of many that I've seen in my short time as a new attending that made me interested, especially in learning about healthcare disparities in hand surgery and the issues that our patients face. So there's tons of different components within healthcare disparities, and I want to focus on just a few of those and the literature that I found to support these issues. The first of which is talking about health literacy, followed by language and cultural barriers. Health insurance issues, which we know firsthand working at the General and in the city how big of an issue this is. Access to specialty care, which is important for hand surgery. Follow-up, not only with us, but also with occupational therapy. And then lastly, what is the distribution of hand surgeons in the United States? How does that affect patient care? Health literacy is increasingly recognized as a contributor to health disparities and ineffective patient care. And Menendez et al. Defined health literacy as the ability to obtain, process, and understand information and services to make health decisions. Through the literature, they've determined that half of all American adults, which equates to about 90 million people, have issues with health literacy. And that is particularly difficult when understanding and acting upon medical information, which puts them then at risk of misuse of health services and adverse outcomes. These patients, unfortunately, have insufficient knowledge about their disease prevention, about management of chronic illness. They have lower health status. They have more frequent hospitalizations and more ED visits as well. And ultimately, they're more dissatisfied with their care. And there's many reasons why patients maybe want to hide their health literacy issues. They may be self-conscious, they may be embarrassed, they maybe don't want to speak up or advocate for themselves, they don't feel empowered to ask questions. All of these things are huge issues when it comes to our patients. So this is a study assessing if patients with limited health literacy ask fewer questions during office visits with hand surgeons. And this was looking at 80 different office visits that were audio recorded in one of 3 orthopedic surgeons. And these were all new patients to these orthopedic surgeons. Importantly, and unfortunately, with a lot of the health literacy data is the inclusion criteria are that they must be adults and that they are English speaking patients. So I thought that was a really important detail to understand about this study. They determined the health literacy of patients via the newest vital sign, health literacy test, also known as NVS, which is a validated test that's based on a nutrition label from an ice cream container. The overall scores range from 0 to 6, and limited health literacy is deemed as a score of 0 to 3, and adequate health literacy is deemed as a score from 4 to 6. What they noted from looking at these patients were that patients with limited health literacy asked fewer questions, than the patients that had adequate health literacy. And also, they asked fewer questions specifically regarding their therapeutic regimen and their underlying condition. Additionally, as can be seen in this table or in this graph on the right, health literacy correlated with the total number of questions asked by patients during the visits. So you can see that as their health literacy score increases, there's a direct linear correlation with how many questions were asked. They additionally found that non-white patients asked fewer questions than white patients did. And what I thought was especially interesting was surgeons rarely asked if patients had further questions, only about a third of the time. When they did ask patients those questions, if you have any other questions at the end of the visit, the vast majority of patients came up with questions to ask the surgeon. And I thought that was a really important point because I think that's something we need to focus on more as providers. Another study by Menendez and his group looked at over 220 new patients seen by 1 of 5 orthopedic hand surgeons, and they timed these visits. Again, importantly, the patients had to be adults and they had to be English speaking to be included in the study. The vast majority were Caucasian at 82%. And what they determined via the same NBS literacy test was that 1 in 3 patients had limited health literacy. These patients were more likely to be older, female, non-white, publicly insured, and not currently working at the time of their visit. These patients also with limited health literacy had mean visit duration of 1.9 minutes shorter than those with adequate health literacy. And 2 minutes in the grand scheme of things doesn't seem like a lot of time, but that equated to about a 20% shorter visit when looking at patients that had adequate health literacy, which is a big difference. They noted that longer visits were associated with patients that had greater magnitude of disability. As you can imagine, the harder the problem, the longer the visit. Also, patients that were getting second opinions, non-specific arm pain or compression neuropathies, and operative management were also patient visits that were longer. Another interesting aspect that I thought was fascinating was that visits that were seen or patients that were seen with a resident or a fellow were 4.3 minutes shorter than patients without a resident or fellow. And I feel like this is kind of funny because oftentimes when we have residents with us, the patients are saying, oh, I was waiting so long, my visit was so long. And yet for some reason, these patient visits were actually shorter. They also noted that the resident and fellow visits had no difference in terms of time between adequate and limited health literacy. So maybe there's something that changes between the time that you're a trainee and the time that you're the actual attending surgeon. I don't know, but either way, I thought that was an interesting finding. These visits are likely shorter as the patients may be asking fewer questions. Maybe the patients that have limited health literacy feel less comfortable voicing their concerns, or they felt less involved in the decision-making. And the other side of the coin is that maybe the physicians felt less concerned by these patients. Maybe they didn't feel quite as comfortable talking to these patients because they couldn't communicate effectively with them. And then last but not least, you have to worry about the unconscious bias that obviously contributes to these healthcare disparities. There were limited studies that looked at Spanish-speaking patients, and I couldn't find really any other studies in hand surgery that had to do with other languages. But the next two will focus on Spanish-speaking and cultural barriers. And the purpose of this study in particular was to determine the prevalence and the factors associated with limited health literacy among outpatients presenting to an urban academic center, and specifically a hand surgeon. Importantly, out of the 200 patients that they surveyed, only 31 patients were Spanish-speaking patients, which equated to 16%. The vast majority, as you can imagine, were Caucasian patients yet again. And they determined that 43% of these patients had limited health literacy. Within that group, they found that, as you can see here on the right, the English-speaking patients are in the blue and the Spanish-speaking patients are here in the red. All Spanish-speaking patients had limited health literacy on a scale of 0 to 3, which I thought was very interesting. They deemed that as a confounding factor. The other factors associated with limited health literacy included advanced age, lower income, less education, and if they were publicly or uninsured as well. And so it's important to realize these barriers that patients have and understanding that maybe the patients that you see on a daily basis are included in these, and how do you deal with that then in your office, talking to these patients about surgery. The other study that spoke about the difference between English and Spanish speaking patients specifically focused on patient satisfaction. And as we know, patient satisfaction is a key dimension of patient-centered care. And although patients that are more satisfied with their care don't necessarily have better outcomes, but they are more likely to comply with their treatments, they're more likely to follow up and keep office appointments, and they're less likely to file complaints and lawsuits. So I think it's still a very important aspect of our job. This study specifically asked patients after their office visit, a total of 75 English and 75 Spanish-speaking patients. They talked to them about their sociodemographics, their pain intensity, and then they also did a satisfaction survey. This was with one provider, and importantly, no translator was used for the Spanish-speaking patients. This provider is proficient in English and Spanish. However, he is not a native Spanish speaker and he does not consider himself Hispanic, which I thought was an important caveat. What they noted was that 91% of English speakers, as you can see here in the light gray, were satisfied with the physician, as opposed to 79% of Spanish-speaking patients. They also noted that Spanish speakers were less likely to be satisfied that the provider listened carefully, that he spent enough time with them, and that waiting times were too long as well. What was important about this particular study was there was no difference in the total time that he spent between seeing the patients of each language. So he spent the same amount of time in the office with the English speakers as he did the Spanish-speaking patients. And then there was also no difference in regard to the provider showing respect, clarity of communication, or explanation of what was done. And they found that independent predictors of patient dissatisfaction were younger age and Spanish language. Spanish-speaking patients were also significantly younger. They were less educated and more frequently unemployed than their English-speaking patients. And then they also reported greater pain intensity scales than the English-speaking patients. The other barriers is, of course, the effect that health insurance has on our patients' access to care. As a whole, Medicaid patients we know are sicker. They have often more complex issues than patients with private insurance. And the reimbursement for office visits, hospitalizations, and procedures is significantly lower than other payer groups. Although Medicaid expansion occurred in 31 states and in DC as well, the Medicaid enrollment has increased by over 25%, which is a huge increase in Medicaid expansion. And with lower reimbursement rates and higher complexity of care, many physicians just choose not to accept Medicaid patients because they just don't want to deal with the issues that they have. And this ultimately leads to longer wait times, longer travel time to see somebody that can take care of you, and then leads to decreased access to care for this subset of patients as well. Odom et al. Assessed variations in reimbursement for 4 common hand procedures, including carpal tunnel and cubital tunnel release, ganglion cyst excision, and interposition arthroplasty over a 10-year period between 2005 and 2015. And they examined over 3,500 procedures. What they looked at was what type of insurance the patient had. You can see on the graph on the right, the light green is private insurance, which is the largest subset of patients, followed by Medicare, which is blue. Dark green is workers' comp, and then yellow is Medicaid. And they found, and they looked at the reimbursement for the submitted charges for the same procedures. Workers' compensation by far reimbursed the most at 65% on average. Private insurance was just over 50%. And Medicaid and Medicare, which is important, were statistically similar at around 25%. So the reimbursement rates for Medicare and Medicaid are actually the same. However, another study by Kim et al. Had this was kind of a funny study. He had a research team call 240 surgeons in a total of 8 different states, and they requested an appointment for their fictitious mother, acting as if she needed a carpal tunnel release for carpal tunnel syndrome. Each office was called 3 separate times, and they assessed the responses for different insurance types. So they talked about Medicaid, Medicare, and then Blue Cross Blue Shield or private insurance. And for each call, they recorded whether an appointment was given and whether there were any barriers for that appointment in terms of needing the referral. What they found was that patients that had Medicaid were only offered an appointment 20% of the time, whereas patients with Medicare and private insurance had a much higher appointment rate, 89% for Medicare, and private insurance was almost 100%. The other interesting thing they found was that states that had Medicaid expansion had easier times scheduling appointments, and experienced fewer requests for referrals from their primary care doctors. And like I said in the last study, as we know, carpal tunnel release, the reimbursement rates are similar for Medicaid and Medicare. However, the appointment success incidence for Medicare was 5 times higher than that for Medicaid, which I found especially interesting. And I think it has to do a lot with the negative connotations that Medicaid has in our minds and our unconscious bias that we have on these patients. The other issues is looking at access to tertiary care centers, especially if you have a more complex issue. This is a study out of WashU in St. Louis, and they systematically examined the impact of insurance status on access to and utilization of specialty hand care. They hypothesized that Medicaid patients or those without insurance would have greater difficulty accessing care, both in obtaining local surgical care and reaching a tertiary center for appointments. This was a retrospective cohort study that included all new patients in a 12-month period, and they categorized insurance status and also clinical complexity. And what they found was that increasing clinical complexity significantly correlated with increasing driving distance to the appointment. And patients with Medicaid were less likely to present with quote unquote simple clinical complex issues. You can see here on this graph on the right that the yellow are patients with private insurance and the maroon are patients with Medicaid. As the distance between the hospital and the patients gets larger, the maroon circle or the maroon pie cut gets larger. And so those patients had to travel much further for the same care. They also showed that primary care physicians reported that local surgeons only accepted 62% of patients with Medicaid as opposed to 100% of patients with private insurance. And so therefore those patients had to travel to the tertiary care center, which is much further away. And they also noted that patients with Medicaid were more likely to fail to arrive for those appointments than patients with private insurance. Zubovic et al. Did a retrospective cohort study where they reviewed records of adult patients with acute hand injuries that were referred for outpatient follow-up after being seen by plastic surgeons in the emergency room at a level 1 trauma center. They looked at different types of insurance, no insurance, Medicaid, Medicare, and private insurance. And the outcomes they looked at included completion of outpatient follow-up, hand therapy participation, and emergency department return visits. The factors that were significantly associated with failure to follow up included male sex, Medicaid insurance, and lack of a driver's license. Race was not significantly associated with failure to follow up. And uninsured patients had significantly lower rates of attending hand therapy when compared to privately insured or Medicare patients, which, as we know as hand surgeons, hand therapy is such a huge component of our job and making sure that patients seek that care and get follow up with those therapists because they really help us make the surgery look good. Another study out of Stanford looked at the epidemiology of amputation and factors associated with escalation of care after presenting to the emergency room. And they hypothesized that disparities in care after digit amputations exist. They looked at over 45,000 patients. The vast majority, at 82%, were men, and they looked at both thumb and finger amputations. What they noticed were that factors associated with escalation of care were positive predictors of care, were high income zip code, machinery related mechanism, self-harm, thumb amputation, interestingly, Medicaid and Medicare, trauma centers, and teaching hospitals. The way that they kind of explained the Medicaid, Medicare, which I was surprised by, is that Medicaid expansion under the Healthcare Reform Act actually resulted in significant increase in replantation reimbursements. And so I thought that was interesting. The other phenomenon they discuss is secondary over triage, which, as we know, is where patients are transferred when injuries that could have been treated at the primary hospital are then transferred because of their underlying insurance. And this more frequently happens in patients that have Medicaid. Female sex was noted to be a negative independent predictor of escalation of care. And these were specifically patients that were female who were from lower socioeconomic neighborhoods. And they don't necessarily have access to trauma teaching hospitals. They were less likely to receive a higher level of care, and that included replantation. And ultimately, that's really concerning because you can't control what sex you're born as. It's a non-modifiable patient factor. And that not only affects the likelihood of patient replant success, but also their access to replantation. And these operations can have significant benefits in terms of their use and function and able to function in society. And last but not least, looking at the hand distribution of surgeon or the hand surgeon distribution in the United States. This was a study by Rios Diaz et al. They looked at over 2,000 hand surgeons, and they determined that the vast majority at 72% are orthopedic surgeons, followed by 18% of plastic surgeons and 9% of general surgeons. And only orthopedic surgeons were represented in the District of Columbia, Hawaii, Maine, Montana, and South Dakota, whereas there were no plastic surgeon representation in Alaska, Delaware, New Mexico, or North Dakota at the time of this study, which was in 2013. They also looked at the hand surgery fellowship distribution. There were 157 hand fellowship positions nationwide, and these fellowships were offered in a total of 30 states. Only one state had a general surgery hand fellowship. And they noticed that there was a positive association of hand surgeon density and per capita income at the state level. In fact, for every $100,000 increase in per capita income, the risk-adjusted predicted mean number of subspecialist hand surgeons per 100,000 population increased by over 3. So that's a big difference. They also noted that there was a positive association of subspecialist hand surgeon density and fellowship density. So the more there are hand surgery fellowships, the more likely that surgeons are going to congregate and work in those areas for the camaraderie, for the community, etc. And so the question remains, how do we contribute as surgeons to these healthcare disparities, especially in orthopedics and hand surgery? Currently in the United States, the minority groups, including Hispanics, African Americans, Asian Americans, and those who identify as more than one race, constitute more than 30% of our population. And as most of us know, more than half of the population is women. These quote unquote underrepresented minorities, however, are projected to become the majority by 2045. And you can see in this graph here, the light blue is indicating Caucasian people. And by 2060, that should be less than half of the population. Unfortunately, the history of diversity in orthopedic surgery has really only been present for about 20 years. In 2000, 2.7% of orthopedic surgeons were women. The first female residents were really recorded in 1968, and that only accounted for 8 residents in total. The AOS census also did not even address race until 2004, where they deemed that 89% of orthopedic surgeons were Caucasian and 9% were of minority race or ethnicity. These numbers are from the 2018 AOS census, and they show that practicing orthopedists who are female are only 7.6%. As you can see here, the younger groups obviously have more females than the older groups represented. They also noted that the number of women in residency has slowly increased since 2004 and is currently hovering about 14 to 16%. From 2009 to 2014, there were 30 programs that had no women in at least one of the 5 years. And there were 8 programs that had no female trainees at all during that time period. And what they also noted was that consistently the same programs seem to attract and train female orthopedists in the United States. The AOS census in 2018 also showed that only 15.3% of orthopedists are considered minorities. And of these minorities, Asian Americans comprise the highest at 6.7%, followed by Hispanic and African American orthopedic surgeons. Adelani et al. Examined the overall percentage of underrepresented minorities in residency, and they determined that the total percentage of these residents is actually decreasing over time, which I think is really unfortunate for many, many reasons. On average, minority residents comprise about 6% of the orthopedic residents in the United States, which was at 9.3% in 2002 and was down to 5.9% in 2016. And again, the vast majority of programs have at least 1 year without underrepresented minority residents in their program, and only 2 programs consistently trained a high number of underrepresented minorities. When you compare race and gender, time and time again, there are statistically significant differences in that female practicing orthopedic surgeons tend to be more diverse than their male counterparts. And then when you look into fellowship, Poon et al. Assessed the trends in racial, ethnic, and sex diversity from 2006 to 2015 for fellowships throughout the United States. As you would imagine, the vast majority of fellows were Caucasian, and of the minorities, Asian fellows were the most prevalent, followed by Hispanic and then African American fellows. Females were accounted for about 13% of fellows during that time period. And she looked at the differences in the groups and their tendencies to go into certain subspecialties. She noted that Asian fellows preferred adult reconstruction and spine surgery, whereas Caucasian fellows preferred sports medicine, hand surgery, and trauma surgery. She noted that the proportion of African American fellows had increased in spine surgery and the proportion of Hispanic fellows increased in trauma surgery during this time period. And there was a significant increase overall in the percentage of female fellows during the analysis, independent of subspecialty, which is great news. In general, females preferred pediatrics, hand surgery, and tumor. And the proportion of female fellows significantly increased in sports medicine during this time period as well. When looking at diversity in hand surgery, there's much less literature. However, there's a little bit. And looking at the most recent values from Brotherton et al. From 2018 to 2019, they looked at the percentages of women and underrepresented minorities. They found that there were 27% of female trainees, as opposed to, and 72%, or the vast majority, were Caucasian trainees. 19% were Asian, 3% African American, and the smallest percentage was Hispanic trainees at 1.5%. During residency training process, there's obviously a decrease in the proportion of female surgical trainees because women currently represent 15% of orthopedic trainees. Plastic surgery trainees include 25%, and general surgery trainees, 37% are women. And so what they look at within hand surgery is these three groups comprise all of hand surgeons in the United States. But unfortunately, as we know, orthopedic surgeons represent the largest applicant pool that contributes to the hand surgery fellowship match. So a lack of female orthopedic residents likely is a contribution because of the underrepresentation of women in orthopedic surgery. And therefore you get about 20% of current trainees as women. The purpose of this study was to define and compare gender diversity among faculty and trainees within hand surgery fellowship programs. And they looked at the gender of each program director for all orthopedic and fellowship resident programs. And they looked at hand fellowship programs specifically at plastic and orthopedic surgery hand fellowship programs. They also looked at the list of hand surgery fellows from 2014 to 2019, and they looked at the gender distribution, and they compared the faculty to the gender distribution of their fellows. What they noticed was that hand surgery fellowship programs had the second highest percentage of female fellowship directors at 13%, behind orthopedic oncology at 27%. There were only 15% of female and total faculty positions out of 614 total faculty positions. And of the 89 hand surgery programs evaluated, 60% of those had at least one female faculty member. Half of the programs that had a female program director had an additional female faculty member, but the other half did not. And the other interesting findings were that of the 849 prior fellows identified over this 5-year time period, 25% were female, and 79% of programs had at least one female fellow in that time period. Hand programs that were led by a female program director did not have a higher percentage of prior female fellows compared to programs with a male director. And 20% of plastic surgery hand programs had female fellowship directors compared to 13% of orthopedic fellowship programs, which makes sense because there are more women in plastic surgery than there are in orthopedics, but still, it would be nice to have those numbers be a little bit more even. Another study looked at ethnic and gender diversity in hand surgery trainees. They evaluated whether the lack of diversity in plastic and orthopedic surgery persists into hand surgery throughout the assessment of the trainee demographics. And they looked at the ethnic diversity in hand, orthopedics, and plastic surgery from 1995 to 2012. And they looked at the changes in proportions of African Americans, Hispanic, and Asian trainees. The percentage of non-Caucasian trainees in hand surgery was significantly higher than that in orthopedic sports medicine and orthopedic surgery in general, but overall was lower than general surgery. And the percentage of female trainees in hand surgery was significantly higher in hand surgery as opposed to orthopedic sports medicine and orthopedic surgery, but it was significantly lower than compared to plastic surgery and general surgery as well. And so you can see here that there has been a steady increase in African American and Asian fellows as seen by the blue and the green lines. However, Hispanic fellows did not have an increase over that time period. Lastly, to look at the overall leadership of our hand society, the American Society for Surgery of the Hand is the most common society meeting that's attended. And IRPA et al. Set out to assess the diversity among its members, its annual meeting attendees, and the annual meeting presenters from 2010 to 2016. And they found that membership in general to the ASSH increased by 30% in that 6-year time period. And that was primarily because of the international membership that greatly increased by 136%. Among the US members, the percentage of women increased from 9 to 14%, and underrepresented minorities increased from 7 to 17%, which is a huge jump. Additionally, they noted that female presenters ranged from 8 to 16%, and international presenters had more women, anywhere from 7 to 18%. And the other great value that they noted was that underrepresented minority presenters ranged from 21 to 32%. So even though they had a much smaller representation, they were seen on the public forum at a much higher scale. Schiller et al. Looked at this study to determine that who the fellowship directors are for hand surgery, what is the composition of that group. What they found was that 86% are men, 71% are Caucasian, and the vast majority are orthopedic surgery trained, which makes sense because that's where most hand surgeons come from anyway. However, when looking at the ethnic minorities, 21% were Asian, 3.6% were Hispanic or Latino, and 3.6% were self-reported as Middle Eastern. There were no African American fellowship directors in this time, and the study was performed in 2020. And the mean age of fellowship directors was 55 years of age. Additionally, they looked at the time period between them graduating from fellowship and becoming a fellowship director, which averaged at 11 years. And as you can see, the mean duration of fellowship directors for a long time, I feel like much longer than a residency director at 17 years. And so that's really important when you're looking at the leadership in our community and who we see as leaders. McCullough et al. Looked at whether increased female representation translated to representation at different levels of the organization at ASSH as well. And they looked from 2014 to 2018 at the active membership of the ASSH, which increased by 13%. Specifically, female active members increased by 34%. And they considered leadership positions as appointment to committee chair or to the council, and also acceptance to the Young Leaders Program. Unfortunately, the committee position, female representation, only increased by 1% during that time period, but the Young Leaders Program female representation increased by 13%, which was a large increase. The committee chair female position representation increased from 6 to 23% in that time period, and the council percentage of women to men varied from 8 to 23% in that time. When they were able to, they looked at the time for advancement through various leadership positions as well, and this was analyzed by gender. And what they noted was there was a steady increase in the percentage of women within the ASSH, and that female ASSH members applied for early career leadership positions at a much higher rate and achieved these positions much earlier than their male counterparts. So fortunately for us, it seems that the ASSH does support women in leadership positions, which I think will lead to more diverse representation, hopefully within our field. So in conclusion, as we know, our patient population continues to increase in diversity. And increasing the number of women and minorities in orthopedic surgery, and specifically within hand surgery, may help to prepare a more culturally competent workforce. Ultimately, I think it's important for us as surgeons to gain knowledge and to understand the barriers that our patients face when they're accessing care, and especially hand surgery, which is subspecialized. And it's important for us to reflect on our own biases towards our patient care and understand that maybe when we're having difficulty communicating with the patient, it's because they may not understand what we're saying, and maybe we need to come at it from a different direction. And I think ultimately clarifying the understanding with our patients, teach back, asking them to ask questions and allowing for more space to discuss their concerns will really allow for better patient care, and I think better patient outcomes ultimately. Thank you so much.
Great. Thank you, Dr. Santiesteban. That was wonderful. And we could open it up for any questions, comments. Let's see, Dr. Vale, I see that you unmuted yourself.
Yes, I did. Thank you. So Dr. Santiesteban, thank you. That was a great overview and insight into a lot of things. And what struck me was that it seems like in hand surgery, doing a little bit better overall in diversity, particularly with women. I'm not sure about the distribution of doctors relative to the economic factors in the regions. It looks like that might reflect all specialties or just doctors' preferences in general.
Right.
My question though is, you chose hand surgery. You're female. Why? What's your sense of how of why hand surgery is having a little bit more success maybe than other subspecialties? And is there something that the rest of us could take from your experience or your observations?
Well, I think as orthopedics in general has maybe a bad reputation when it comes to women. I think a lot of times there's the kind of brute that you think of when you think of a classic orthopedic surgeon, of using heavy instruments, heavy tools, using a lot of strength. And I think that what's nice about hand surgery is it's not necessarily about that, but it's more about your knowledge of anatomy, more about creativity. I think it's maybe a little bit more artistic personally. We get to deal with all different types of soft tissues as well as bony fixation. And so I think that kind of lends maybe more to attract more women to the specialty. I think additionally, like I said, I think it really stems from leadership and mentorship. And I think when you have strong leaders in the community that you see, and somebody looks like you and acts like you, it's much easier to relate to that field. However, the reason I went into hand surgery, I didn't have any female hand surgery mentors in residency. So I think that you can still find mentors that maybe don't look exactly like you, but it relate to you in some way or some fashion. But I think that could be a contributing factor, for sure.
Sounds like the rest of us need to work a little bit harder.
Exactly.
Thank you.
See, hand up from Dr. Wostrak.
Thank you. That was an amazing talk. Thank you so much. I was hanging on every word.
Thank you.
It's something that I'm really interested in our own practice, at the Cancer Center. One of the metrics that we're constantly trying to achieve is booking new patients within 7 days or within 14 days. And one thing I'm interested in is the back office work that goes into getting patients with poor insurance in at the same time and getting the MRI they need, in a timely manner. And my assumption is there's a lot of extra work that our staff is doing. Have you seen any studies looking at that or quantifying sort of the women and man hours that it takes to get patients with poor insurance the care they need?
I didn't see any studies specifically in hand surgery. I would imagine that there are some within orthopedics in general. I would hope there are. But I think, we all know how hard our staff work in terms of getting patients in. Oftentimes when I have patients with partnership health plan, like my patient, I talk to my practice coordinator right away because I know now, after learning in a very short time period, how difficult it is for them to access hand therapy after surgery. And so trying to get them in sooner rather than later to hand therapy is really important. And I've also had many discussions with patients, unfortunately, that I say, listen, I'm not going to do surgery until you have the hand therapy scheduled and have it on your calendar. Because, you know, I keep seeing these patients that are really delayed presentations for so many reasons. And unfortunately, if they don't have hand therapy, no matter what surgery I do, they're not going to do well. And so for me, it's really kind of taking the time with the patient, trying to understand if they have issues to care and making sure and following up on that as well. But I think there is definitely a lot of potential to look into research about how much time on the back end, right? What do our call centers hear on a daily basis? I'm sure that would be a very interesting thing to look at too.
And I would just sort of plant this seed for leadership. It almost seems that there might be a role for something like an orthopedic nurse navigator or a navigator, where we understand the risk factors for extra hours, and then, you know, try to put resources into some of those patients. But thank you, that was a great talk.
Thank you.
And then Dr. Baldwin.
Hi, thanks for this talk. It was really great, Dr. Santiesteban. My question, and I think you kind of highlighted in Dr. Wistrak's comment, is it seems like part of, like, you know, there are many aspects, like you mentioned, about healthcare disparities, but one big part is access to hand therapy. And what I remember being on hand, and correct me if I'm wrong, is we don't necessarily have any affiliation or like a hand therapist that patients have easy access to. Like, one, I know the wait list is long, but one thing I think of, like at the OI, there's, you know, this whole PT on the floor where you can say, oh yeah, it's just upstairs, and there can be easy communication and coordination like through those two means. Are there models of like hand services, or do you think it would improve if we were able to kind of have a hand therapy model like that? I understand it wouldn't necessarily improve the distance that patients have to travel if they're already traveling from Marin to, you know, UCSF, but then maybe once they get here, they know, you know, I have this available to me within here.
I'm looking at Dr. Schroeder's face because I know I know how we all feel about this. So
yeah.
But go ahead. And well, I will also chime in.
Ivana,
I could be completely wrong though. Sorry.
No, you're totally
near
right.
And dear
100%.
to the hand service. So we've been trying to get hand therapy back to UCSF, and it's like on the horizon, coming soon. So just from models, I trained at WashU, and there was actually a hand therapist in hand clinic every day. And so it was, it's, you know, similar to what we have at San Francisco General, where you can get an immediate splint, and at least for somebody who may be traveling from very far, they can get a home exercise program and the appropriate splint set up. And so that's what we're aiming for here at UCSF. It's been a space issue, it's been a funding issue, but if things work the way that we want them to work, Dr. Vale, we have plans for rolling this out actually in July of this year. So now I'll swing it back to Dr. Santiesteban.
Yeah, I was just going to say, you know, the nice thing about, I think, what you guys have access to as residents here is seeing the difference between the general and our private practice at the OI. You know, at the general, I can't even imagine if we didn't have hand therapy there with us in clinic. I don't know how we would have patients access care and access the resources that they need. There's such a vital aspect to my education, to your education, but also to helping patients get where they need to go in terms of their hand function and get back to being functional members of society. So I think it would be amazing if we could have hand therapy here, especially with us in the office, because I've seen models like that where, one, it's nice to just be like, hey, this person needs a mallet splint, and then they don't have to see anybody. They don't have to take time out of their schedule to go make an appointment with a hand therapist that's not going to be available for 3 weeks, and then get delayed care and all those different things. I mean, there's simple things that we can do and such an easy one-on-one basis if they were with us right there. So 100%, Iviana.
Great. And see, Dr. Sabatini.
I have a comment and then 2 questions, although it looks like maybe Dr. Schroeder just brought up something there. But so one, Lauren, you should join us on the diversity committee. And because if this is an interest of yours, then you should join the rest of us who are actively doing work in this area in the department. So please join. My first My first question was actually, I found it very interesting. I've done a variety of work around access to care for children, comparing Medicaid to private insurance. And I was really struck by the study that you brought up that showed that, and very interested to hear that for Medicaid versus Medicare, the reimbursement is actually the same for carpal tunnel. It's certainly not the case in peds. There's a great disparity between, well, we don't have Medicare, obviously, but there's a great disparity between Medicaid and private insurance rates. So I'm just wondering your thoughts on why that disparity exists. And I think you alluded to, sort of some unconscious, I would probably propose that it's conscious bias against the Medicaid population. But wondering some thoughts on that, some opportunities to maybe educate the hand surgery population that in fact you will get paid the same amount. So just wondering your thoughts on why that disparity is so significant when it's like 20% versus 80%. And then my other question was just sort of the role of telehealth in eliminating or reducing disparities, particularly when it comes to hand therapy. And is there a role for that? But Schroeder has brought that up. So those are my two questions.
So I think exactly like you said, unfortunately, I think there is a conscious bias, implicit bias when it comes to Medicaid patients, the negative connotation that a lot of physicians have maybe seen firsthand. I don't know what their experience was early in practice, but oftentimes private practice does not accept Medicaid. I'm sure there's many reasons why that is, whether it's just more difficult to get the reimbursement. I don't know. I'm not in private practice, so I don't know. But I think that the huge component is, like I said, those patients tend to be sicker. They tend to have delays in care for many reasons. They tend to have more complex issues. And I think those are big barriers to their healthcare, not only their insurance. So I think it's less to do with the reimbursement maybe, and more so to do with the overall patient population that is usually included within the Medicaid patient population. In addition to that, I think telehealth is a huge benefit. The problem I've seen with that is some of my patients don't have computers. They don't have internet. They're older patients that don't have my chart. We all know, I've asked patients all the time, do you have my chart? And they'll be like, no, I don't know how to do that. I don't want to do that. And I'm like, okay. So then you have to find other ways of communicating with them. And I think there are barriers to that, even though telehealth is a huge advantage, especially for patients that live far away. It's also, will the insurance cover that? I don't know, especially if they're Medicaid and county-based and things like that as well.
Dr. Bervin.
Yeah, Dr. Santiesteban, thanks for sharing some terrific insights, both in terms of trainees as well as access to care. And I'm curious with regard to your experience at the General compared to your experience at Marin. What are your thoughts about, in the US now, we have almost 1 million people a year who are personally bankrupt due to healthcare costs. The problems in access to the fee-for-service system, you've really emphasized the fact that that this person, if they were at San Francisco General Hospital, I think would have had much better access in the integrated healthcare system. So what are your thoughts about the fact that our academy and really a lot of us in the department are complicit in this by being committed to a fee-for-service healthcare economy by actively opposing a universal healthcare option and by not really trying to actively participate in integrated healthcare systems?
I think it's a difficult discussion, right? Because I think as a group, we understand the problems. It's a matter of wanting to actually do something about it and what that entails. I think it takes a very special person that is more involved in politics, that wants to get involved on that side of things and actually make those changes. But I think so much of it has to do with the history of healthcare in our country, and the fact that I think Americans in general like tradition in a lot of ways, and these things were created to try to make the healthcare system better. With Medicaid expansion, it has helped, but it's kind of like a Band-Aid on top of, a fire hose. I think it's not quite fixing all the problems, and I don't know the answer. I'm sure that there are other healthcare disparities in terms of access to care with the universal healthcare system too, in terms of how long it takes to get in for surgery for carpal tunnel syndrome, et cetera. So I'm sure I don't think there's a perfect system out there, unfortunately. If there was, that would solve a lot of our problems. But I do think that it's a very I was expecting my Marin practice to be kind of bougie, and it's really been a lot of Medi-Cal patients. So I've been really pleased with that because those are the patients I prefer to treat anyway.
But in some ways, those are patients who are most disserved by
They are.
not being in an integrated system, right?
Exactly.
Those patients who actually are the least advantaged or the most disadvantaged, those are the ones who are most likely to actually end up becoming bankrupt because of their healthcare costs. Doesn't
Right.
happen anywhere else in the world.
I know, isn't that crazy? It's a messed up system. I don't know the answer, unfortunately.
With that, we'll go to Dr. Casalino.
Thank you so much for the awesome talk. I was really struck by the one paper talking about the health literacy comparison between the English and Spanish speaking patients. And I think we're fortunate here that a lot of our providers speak Spanish, and then we also have great interpreter services available. Do you have ideas for how to improve that? I just thought like there was a significant portion of that study that showed that the Spanish speaking patients, 0% were able to answer a question about their care. And like, do you have ideas for how else as providers and as a team, we can sort of help improve the care of our Spanish speaking patients so they walk out of clinic actually understanding at least one thing that happened during clinic?
Well, I think what's nice about our group and our residents is oftentimes they're native Spanish speakers, right? So they grew up speaking Spanish. I think patients often will relate more to that when it's a native Spanish speaker as opposed to a white person speaking Spanish, even though they're speaking the same language and able to communicate. Like I said, we've seen that minorities tend to do better when they see minority physicians that look like them, speak like them, act like them, or from the same backgrounds. And so that's why I think first and foremost, we need to get more women and underrepresented minorities within the field of medicine and then also within orthopedics. I think that's kind of the first stepping stone. But on top of that, I think just taking more time and asking if they have questions, because like one of the studies I showed said that only 30% of surgeons actually asked, do you have any questions? And when they did ask that, so many patients had more questions. I think opening the floor, leaving it to try to make it so it's a more cohesive and collaborative work environment when you're talking to patients about their healthcare and less of the paternalistic, this is what I think, this is what's going to happen. I think that can maybe help with that system, but I think there's, I don't know, open to all ideas.
Thanks.
Dr. Miklau.
Yeah, hi, good morning, everybody. Lauren, that's great. Thank you so much for talking about that. And it falls nicely on the subjects that we've been covering as well, about the DEI work that's being done and ways to try to overcome that. It's more of a comment than a question, and that is that given your interests and areas of expertise, and you're a native Spanish speaker, the question I have is, what sort of things could you do at a county hospital system? But specifically, we do have, it sounds really ripe for a quality improvement project. And I would also set out an appeal. I was going to send a note to the residents that next year's programs are being developed for resident quality improvement projects as well. And that there's a little stipend that's attached to that if they achieve the metrics. But that would be great if you could develop something like that would continue to improve the care that we're giving to our patients at the general.
Absolutely. Absolutely. And I would love to develop actually pamphlets that are, about common, I think we've talked about this in the hand pod, but common conditions that are in different languages to just really make sure that patients have materials to read and access to that material in order to just understand common things like what is carpal tunnel, what is a trigger finger, instead of just assuming that they're going to translate the English printout to Spanish or Chinese or whatever it may be. So,
Lauren, just so you know, we actually did that like 7 years ago. We actually had, we did some type of grant, a patient care grant through the general, and had all of the ASSH pamphlets converted to both Spanish and Cantonese. So they are available in clinic.
Well, that's good to know. Thank you. I didn't even know that. See? I'm still new.
In POSNA, the Pediatric Orthopedic Society of North America, we had all of our material. We have all of our online parent facing educational information now in Spanish. It would be great if all of us, for our individual subspecialty societies, encouraged them to, invest at least in translating that information into Spanish, because it seems a shame for people to pay at individual hospital levels to do that work when this is a national issue. So maybe that's something that we all can advocate for in our various societies, to make sure that that information is getting out there and supporting our Spanish speaking population across the United States.
Definitely. And with that, it looks like we're right at 8:30. So I think we'll wrap up there. But Dr. Santiesteban, thank you again. This was wonderful. Thank you all for being here. If able, plan to join the CC MBM retreat. We'll be off next week for the Academy, but we'll return in 2 weeks with Dr. Ryan Freshman.
Thank you.